Hi, everybody. Welcome. Really excited to have everybody here. We'll get started in a little bit. Just want to thank you for joining us for the IPCIG Chairs webinar series. Today, we're talking about population health, what it means for integrated primary care. As you know, it's hosted by the IG, co-sponsored by the Society of Clinical Psychology, APA Division 12. I'm Yahaira Johnson Esparza, the chair of the IPC interest group. Before we begin, we do have a few items to share. First, this and all society virtual presentations are offered as a free benefit of membership in the Society for Health Psychology. Please feel free to invite your colleagues and students to join to ensure unlimited access to future presentations and other society benefits. Visit our website at societyforhealthpsychology.org for more information. This event is being recorded. Anyone who speaks during it, for example, to ask a question, is agreeing to be recorded and is granting permission for the recording to be posted on our website. The webinar is also eligible for one continuing education credit under the Society of Clinical Psychology Division 12 sponsorship. The evaluation information will be sent via email to all who attend the full presentation shortly after the webinar. We will leave the evaluation portal open for 1 week until 5 p.m. Eastern on Thursday, May 2nd, 2024. CE certificates will be sent via email within 5 to 10 business days after the evaluation period closes, using the email at which you enrolled in this session. All participants are invited to submit feedback via the evaluation, even those not seeking credits. Questions will be taken at the end of the presentation. You may submit them via chat feature during the presentation, and at the end, we'll go ahead and call on you to unmute and ask your question. And now we'll go ahead and just get started. Before we hand it off to Dr. Vogel, just want to give you a very quick couple updates on the IPCIG. Oh gosh, great. Give me 1 sec. Now I've become the person who can't find the correct slide deck, so I'm sorry about that. All right. So I'm hoping that you can see our slide deck. Like I mentioned, I'm Yahaira Johnson Esparza. We do want to let everybody know we need a new chair. I will be stepping off of this position in July, and we are looking for a new chair for the IPCIG. If you are interested, please send us an email. I'll go ahead and add that to the chat. Let others know in case they're interested, and we're happy to talk about what that position will entail. I will let our two ECP associate chairs introduce themselves very briefly, but I also wanted to let everybody know last time we asked for student reps. We now have a student rep, and we'll be announcing who they are in the next few weeks. But I'll let the associate chairs introduce themselves.
Hi, I'm Brittany Houston. I work at UT Austin in the Family Medicine Residency Program, and I'm one of the Early Career Associate Chairs.
Hi, everyone. My name is Meredith Williamson, and I'm the Director of Behavioral Health and Wellbeing at Texas A&M University, and also one of the Early Career Associate Chairs.
Thanks for that. Quick reminder, these are our IPCIG subcommittees. I'll go ahead and send this information to all so that you all have this information. I'm speeding through this because I want to get to the exciting part. Again, the IPCIG Chairs webinar series is really a series with this theme of what it means to be a psychologist in IPC. As you all know, we had an ethics in IPC talk earlier this year, presented by Dr. Gibson Lopez, and now we'll have Dr. Vogel present. We also have a couple other presentations coming on later this year with Drs. Bauman and Beachy and our very own Dr. Williamson in October. But now we will go ahead and let Dr. Vogel take the stage because that's what we're here for.
You want to go ahead and start? Well, welcome all. Thank you for being here today. And let me just make sure my thing's organized here. So what I'm going to be talking about today is population health. and what it means for integrated primary care and specifically the integrated primary care psychologist. So in terms of, since we are offering CME, just to let you know, I have no financial disclosures to report. So what are our learning objectives? So we really want to talk about what are the basic tenets of population health and how it applies to integrated primary care. And we want to understand also what kind of redesign or what are the conceptual shifts for the BHC moving forward to kind of take into consideration population health. Now, when I was a kid, I always asked a lot of why questions, and I like to start my talks with why. And I like Simon Sinek's book, Start With Why, which gives the importance of this for business. If we only know what we do and how we do it, the products we make and how we make them, we're going to lose out on the why behind it. Why are we doing this? And so when we think about the why, it really helps, again, build up to say, why population health? Isn't our current healthcare system of healthcare producing the right results? Are we getting good outcomes with all persons? Are we spending our money well? Well, I think you know the answer to this, and these are sort of 2020 slides. This is even before the pandemic, but the U.S. spends nearly twice the average of other organized for economic cooperation and development countries on health. And if you look at the orange part of the graph, what you'll see is that private spending is one of the big things that pushes up above. So that's what people individually pay, not what necessarily government pays. And so we spend a lot. Are we getting good return on our investment? Well, this graph would suggest not so. The U.S. has the lowest average life expectancy and outperforms worse than average on many population health outcomes and has more outcome-related disparities compared to other OECD countries. So, and you can, in this area that's sort of highlighted here, you can see it's sort of even leveled off over the last years. Again, this goes up to roughly 2020. And there's been some reports that since then it has actually decreased slightly over since the pandemic. So we're not necessarily getting the return on our investment that we would like. Now, many of you have probably seen this slide as well, but this data really comes from a study first in 1993 and then again in 2000, but the trend really continues. And it's estimated that behavior is the most predictive factor of how people die, roughly 40%. It's not genetics, not socioeconomic status per se, or at least all the medical care we receive. You can see that sort of accounts for maybe only 10. I've seen other estimates of maybe 20% of mortality. Morbidity may not have quite as high of a number, but also in morbidity, it also is the kind of the care we receive, and those socioeconomic factors actually may be higher when we look at that. So that sort of leads us to the idea of population health. What is this? Well, public health goes back as far as like the 19th century, but population health science is a relatively new discipline that has only burgeoned in its literature in the past 2 decades. And we might want to compare population health science, which is the study of conditions that shape the distributions of health within and across population, and the mechanisms in which these conditions manifest in the health of individuals. But what we're really talking about here is more the application of health, not population health science, but the practice of population health. Now, the seminal paper of this really came out in 2003, and Gindig and Stodderdat defined what is population health, and they said basically it was the health outcome of a group of individuals, including the distribution of such outcomes within the group. Now, one of the things that this definition has been criticized on is it focused mainly on outcomes. And so that was sort of a narrow focus, if you will. Now, CDC and CMS take a much broader view. They're being national organizations. They focus on, the CDC really looks at how health departments and what's their role of connecting policy to practice. And they really focus on partnerships to achieve health outcomes. CMS definition, on the other hand, is health behaviors and the contextual factors. But unfortunately, it doesn't really define these other contextual factors. So I don't know these two definitions leave us too far along. So let's go to maybe what I would consider a simpler definition. And this one's cited in Hunter Goody, Ord and Dobmeyer's book, Integrated Behavioral Health. And they use this definition by Maris and Nash, in which it's the systematic and integrated approach to improving the health of a given population by changing policies and systems that affect healthcare access, quality, and outcomes. So again, it's systematic, and you're affecting policies and systems in order to achieve your access, quality, and outcomes. So if you think about it in this way, the key factor is you're changing something in how your practice has a policy or a systems that operate that results in this change. So it's not just the individual efforts of clinicians with a single patient, but it's broader changes that affect the given population with better outcomes. Now, this definition I've carried around with me forever. I'm not sure where I got it, but it's my shortcut idea of how to think about the problem. And it is, you're just as concerned about those who do not show up in your clinic as you are with those who do. So our tendency is to focus on the patient who shows up for care. But what about those who didn't, that are at least on the panel of the patient and never show up or didn't show up that day, or you saw them last week and they were supposed to come in today? How do I want to care for those? Or if you broaden your perspective, what about those in the community who don't have a PCP? This is where population health shifts the focus. And the next step in this process of kind of understanding this is recognizing what's your population that you're interested in. Now, as I said, CDC and CMS definitions would take a very broad view of like the geographic US. In primary care settings, we might define our population a little differently. It would at least start with our panel of patients that have kind of been signed up as this is where your primary care is provided. It could expand to maybe even the neighborhood or the geographic region in your catchment area of your patients. And it may also take a narrower focus, maybe specific ethnic groups. Perhaps your clinic is based in an area with a lot of migrant health workers. And so that becomes a population you're interested in. These all become possibilities for your population. And we want to improve the health of all, but we need to start somewhere in defining the populations that we serve. I want to also point out that primary care is already well along this path of population-based healthcare, because as compared to specialty care, we're already having a broader base of patients that come into our clinics or at least signed up in our clinics. And those who are working in IPC have already, I hope you get this out of our talk, have already done a lot of things that is considered population health just by the nature of how we work. Now, so the lens at which you might look at population health also can go from this lots of different ways. Let's say you're a public health director, and you might be more focused on interventions that improve all the lives of people in your geographic area. A community health director might focus on neighborhoods and communities with an emphasis on high disparity communities. Someone in managed care, their focus is on their covered lives, people that are under their insurance plan. And this can expand to entities like ACOs and the like. And I just want to make a note that funding models are really not something I'm going to be talking specifically about it. What I'm talking about is this last column, the primary care physician and the primary care physician's office. And their lens is first on their panel of patients. But again, what I hope you take from this presentation, that there is a beginning to step outside the boundaries of the clinic walls into the surrounding community. And that's where I think population health begins to expand our definition. So APA has been working on this idea, and they've used the pyramid model as a way of describing this population-based health approach. At the top are those that are diagnosed and come into your clinic, probably. There, the focus is on effective and efficient clinical care. Now, the next level up is those at-risk populations, or sometimes called rising risk. Maybe this is your pre-diabetic or someone with an early mental health problem. Now, in integrated primary care, the BHC sees a lot of these patients all the time. Our goals are oftentimes to mitigate the risk and to provide early interventions so they don't rise up to the top, that we don't have to send them off to specialty care. But what about the bottom? These are relatively healthy individuals. Maybe they don't seek care at all. How do we reach this population or keep them healthy, connected, and maybe more focused on making services convenient to this population or offering virtual services? You know, he was our former medical director, he made this statement about healthy population is the most price sensitive. They're less likely than someone else to see a physician. They might see another kind of provider. They want mobility, access, and transparency in pricing, sometimes things that we don't offer as efficiently. One quick note, I want to just compare between public health and population health. They have similar goals, but they're not the same. Public health promotes health and focuses on healthy behaviors, and they also provide a lot of primary prevention, immunizations, things like that, but they may not be concerned about maybe some of the larger social determinants of health, such as education and income, whereas population health takes a broader view. And as this Milken Institute points out, it provides the opportunity for healthcare systems, agency, and organizations to work together to improve healthcare outcomes. And I think as you'll see as my talk progresses, this is a role that I think family medicine and primary care in general has a role in making these connections outside to other organizations to work together. Now, I felt it's important that we just talk about the triple aim. In 2008, when this first came out by the Institute of Healthcare Improvement, it was really kind of an eye-opening, innovative idea. And what they said is that we have to balance three competing factors: cost, quality, and the care experience that patients have of the experience. That it's great to have great quality that people love, but it's too expensive, no one can afford it. Or you can have great outcomes, quality, but cost the patients would experience is not helpful. So I'm sorry, it could be, you know, good cost, but patients find it unpleasant. They don't come back to it. This was later, and everybody here I'm sure knows, was expanded in 2014 to the idea of quadruple aim, because the first one really didn't take into provider experience as part of this. And by the way, I just kind of, it says Ascension Medical Group. That's actually the group I have worked with, and that's where this graphic comes from. But it's really Budmeyer and Stinsky who published this in Annals of Family Medicine with the quadruple aim. So let's take a real simple example. And again, this comes from Hunter and All's book. And let's say you did universal screening of tobacco given to all patients in your clinic. And if someone was interested in quitting, you provided a low intensity intervention, maybe ask, advise, assist stages of it. And, you know, it's a brief kind of intervention. While the low intensity intervention may have a low success rate by itself, it's given to a larger number of people. It was a universal screening for everybody who came in, and therefore would over time have a greater impact than a more intensive intervention provided to fewer number of patients. Let's say, you know, somewhere else has a 5-week stop smoking program, but they only get 20 people in that program. You've reached hundreds of people in your program, right? So that's a very simple example of you're taking a policy and a system and changing it, universal screening in this case, to increase access, quality, and potentially outcomes over time. So if we turn our attention to specialty mental health, again, this slide comes from APA, they would say our attention has been focused on the severely mental health and those with a diagnosis, the two top layers of the pyramid, which make up roughly 25% of the population. But what about the 75% of the population? How are we preventing mental health diagnosis, getting people with early signs, addressing those? And again, that's one of the advantages of integrated primary care, because as mental health providers, we see early stages of this before it might progress to something that needs to get referred to specialty mental health. And so there's been really growing support, and APA has been really leading the charge with some of this, especially with mental health specifically, and that they offered the APA Population Health Summit in 2023. And what they recommended is, again, or they found, is that the disproportionate focus has been on that 25%. And yet that focus leads to a lot of significant health disparities. People who need services are not getting addressed. And so their outcome is there is really a strong consensus that a population health approach to mental health care and prevention really needs to be on the forefront. And from that, they have encouraged their members, committees, divisions, and boards to use this following lens through which activities for health promotion can be viewed: to working across diverse systems to advance population health, working upstream to promote prevention and early interventions, and educating psychologists and community partners in population health. And finally, to enlist a diverse array of community partners in this process, realizing this isn't something as individual providers we're doing, we really need to collaborate. So this leads me to what I hope you take out of this is my 5 conceptual shifts towards population health that we want to think about. The first is moving upstream, and that's looking at social determinants of health more, shifting our focus from individual to entire populations, measurement, kind of what's the role of measurement and how can that affect change, targeting at-risk populations, and boundary spanning role of primary care. So let's talk about each of those in detail. So let's talk first about moving upstream. And again, we're all well aware of social determinants of health, how those issues of affect things. So let me tell a little story, and I use this in my clinically a lot too. This person's walking along the stream someday and hears someone in the river yelling, help me, and they dive in, and they pull them out of the water, and they rescue them, and they say, thank you, they rescued me. And then next thing he hears another, help me, and he dives in and does it again. And he goes, I need to go upstream and see who's throwing all these people in the water, right? So the more we can go upstream and understand why are these patients showing up in our clinic, what's leading to that, and that's really, again, where the social determinants of health are important for us to take into consideration. And so we have multiple methods of affecting health. One is the medical interventions we provide, but there are other interventions that we would consider much more population health related in terms of things we can do in the social environment and the physical environment. And we focus a lot on individual behaviors, but we really need to recognize it's really the interactions between those different factors. The recommendations you might give to someone for exercise, but they live in an unhealthy neighborhood where exercise is not really safe, you're going to have to change a little bit about how you might provide those, contextualize those individual behavior recommendations. So again, moving upstream, what's maybe an example, and this one was again published in 2016. This is part of what was called the Well-Rx pilot study, and that they developed 11-item survey to screen patients on social determinants of health in their clinics. And I listed just some of the things that they asked the questions. Do you find yourself going hungry? Do you have difficulty finding housing, financial insecurity, et cetera, feeling unsafe? And they screened over 3,000 patients in their 90-day period. And what they found is that 46% screened positive for one, but 63% had multiple needs. So 63 to 2/3 of the population is indicating some social determinants of health affecting the healthcare they receive. And what they did is they used medical assistants and community health workers to connect these people with appropriate services and resources in their community. And what came out of this WellX pilot is it demonstrated the feasibility for the clinic that this system became ongoing. And such now is that in the university hospital that they're a part of and the State Department of Health require managed care organizations to have community health workers available for all their Medicaid patients. So again, this is an example of a moving upstream kind of intervention that helps move beyond the walls. And what we have to be aware of is that this wasn't said, this is another job for the primary care physician or the BHC. This is how we could involve community health workers in this process of connecting up individuals. So shifting focus from individual to population. I would offer that, and this comes from CMS's recommendations, that there's really kind of 5 things here we want to begin thinking about. And the first is empanelment is really a core concept. And hopefully all of you in your clinics have already done this, but it's the act of assigning each patient to a provider or a team. And it has this dual purpose of both assigning responsibility between that patient and that team and establishing a denominator. So each team now knows what's my N that I'm trying to affect. I've got X many lives that I'm trying to affect. When data is collected, we know how are we affecting our population, that being the empaneled patients with that provider. And you can compare, is one team doing something better than another team? We can look at those things and be innovative and say one team might implement one method, see how that compares over time to the other teams. Again, it also builds that relationship between the patient and his or provider and their associated team. The second is risk stratification. We need to differentiate patients who require different types of intensive care. We really don't want to have a consistent approach to each patient. We want to contextualize that care. Now, sometimes that is in the process of maybe a standardized tool. We assess all our patients. Prepare is one assessment method that's been out there. But you could also start with something smaller, maybe a single risk factor, frequent ED visits or high A1C numbers, and look at those groups and say, that's a risk that we need to address, and how we want to take anything special into consideration for how we address those things. And each risk can have basic elements of the plan that guide the various patient groups and address the unique needs of each group. The next issue is care planning. Using this sense of we maybe know what our population is and we have a registry of that, we might identify what are gaps for prevention of sort of the of this defined diagnosis, and how can we close those gaps. Use point of care reminders, find other ways to kind of help identify patients who are falling through the cracks. This gets back to my definition of who's the patient who didn't show up that day. You know, I want to take just a quick point of, I remember residents would always complain to me about no-shows. And one of the things I would do when I would talk about no-shows to our residents is I took a picture of our parking lot and specifically the grease stains or the oil stains in front of where the patients parked and where the staff and physicians parked. There was a distinct difference. Transportation is a big issue for a lot of our patients getting to care. And so when we talk about someone who's late for their visit or misses a visit, we have to understand what was transportation involved in that, and are there things we can do to decrease that gaps and make sure that that patient doesn't fall through the cracks because they couldn't get there or it was unsafe or untenable for them to make their appointment that day. The final point in this shifting our focus is medical neighborhood. And this is where the practice begins to strengthen the relationship with other care providers. So maybe there's a team, specialty providers perhaps, that you oftentimes refer to, could be GI or other people, and the primary care team begins to kind of network with these other providers. And maybe there's social services agencies. Whatever it is that begins to make up your medical neighborhood, there's real distinct role that the primary care physician has in the physician group of how they can build these connections with these other providers to begin having a more complete and efficient care for patients that we see. And so this leads to me another concept in this area, which is stakeholder engagement. Oftentimes we tend to think about that we built the clinic, they come, if they don't come, too bad for them. But the idea of, and many of you probably work in FQHCs, they have their model from the ground up of involving community members on their board that help make decisions about how healthcare is provided. And so as clinics reach out to other local community organizations, local governments, and find out what are the needs in this community, what are things that might be affecting their care as they come in. Even if these groups came in, gave a lecture to residents or physicians to kind of understand what are the gaps in care, that helps broaden their perspective of what they may be missing if they're just within their four walls. All right, so this leads me to measurement. And we want to, moving from traditional healthcare to population healthcare requires us understanding the populations we serve. Now, I don't know how many of you are in a nonprofit healthcare organization. So I worked for 34 years in a nonprofit hospital, and every 3 years they're required to do a community health needs assessment. And one year I volunteered, I wanted to participate in this community health needs assessment process because I think it helped me understand how they were collecting this data, and I could actually advocate for some of the issues I thought were important in this. But if you work for a nonprofit, you've never seen your community health needs assessment, go find it, because it will help you understand what your hospital sees as the community health needs in your area, your catchment area. Now, you might also reach out to researchers who are looking at social determinants of health and social risk factors in your community. What are they offering? We have a very distinct advantage in the Flint, Michigan area, in that the Michigan State School of Public Health is based in Flint, not in East Lansing. They're actually based in Flint. They were well positioned for when the water crisis came, that they could help respond to that. But we have great seasoned researchers on staff in our public health that if you reach out to them, they can give you lots of ideas about, where are food deserts in your community? How have they looked at how things that the clinics could do that could help address that? Looking at Healthy People 2020 and 2030, this gives a broad population-based health goals and objectives broken down to categories of health conditions, health behaviors, population settings and systems, and the social determinants of health. Be sure to read through that. These goals and objectives may also be concepts that you can think about, maybe one or two of them apply to your community and things that you can work on. And finally, look at existing clinician-led measures. Several of those measures have indicators of population health. And so again, I go back to my Peter Drucker's comment, you cannot improve what you don't measure. And so think about this measurement. Some of the available clinician level measures that are out there are things like access to care, basic clinical outcomes, coordination of care, et cetera. Each of these can have population-based measures. So one of the things you might want to, again, think about is start with something small. Maybe it's something you have a high level of control over, rate of flu shots or pap smears or things like that. But as you move on to more process and intermediate outcomes, what's one thing I hear our frustration of physicians say, well, I can't make this person eat the right diet, right? No, you can't. That's not our job. Our job is not to control patients, but we can influence them by providing information that helps them make better choices. And so the next thing is looking at our at-risk populations. And again, these are people with access or functional needs, either temporary or permanent, that may interfere with their ability to access or receive medical care. And the list here is not all inclusive, but certainly pregnant women during the time of pregnancy, there are other special needs that we might in our clinics be able to make sure we're thinking about. People with disabilities, limited English proficiency, et cetera. So again, I think one of our jobs is to think about these at-risk populations. How do we reach out of our clinics to kind of address one or more of these groups so that maybe in their preclinical stage, we can do things that help prevent them to getting into the top of our pyramid. Now, many of you have seen the chronic disease management model. This is Wagner et al.'s model that's been out for quite a long time. This model has these 6 elements of self-management support. Again, what I like about that is we're helping people self-manage their chronic illness. We want to deliver systems that are well designed to support them. We need decision support tools that kind of are in the point of when we're delivering it, we know we have data that helps us provide that care in organized clinical information systems. It has our healthcare systems are organized to provide this, and it reaches out to the community. Now, one of the things that I think we have to be careful in primary care is this model has both positive and negative effects. One aspect about primary care is that we really want to focus on whole person care. And so sometimes when we get too specialized and focused just about chronic disease management, we miss opportunities to personalize attention and actions that promote health, healing, and connections. And so we might be working so much on disease care model that we miss things that patients really care about at the moment as well. So one of the things I think we want to be careful about is that chronic disease management can be really good because it's a high cost area. But one of the things that I think primary care does well is recognize problems, prioritize them, and personalize them. And so when we think about that, it's more than just chronic care, but prioritizing with our patients what's most important that we talk about today and what is troubling you the most today that we can help address. So I think it's that balance between the chronic disease management and the prioritization of all the issues they have. Now this gets off in a little, maybe less of specifically population-based healthcare, but I really want to talk about sort of the paradox of primary care. And if you look at quality indicators that sort of a lot of healthcare focuses on, which is really disease-based outcomes, sometimes primary care is seen as not as effective as a specialty care. Yet other evidence, like the medical disease outcome study, shows that with chronic diseases and functional health status, the outcomes with primary care are at least as good, but they're delivered with fewer resources, maybe better quality, and greater equity. So what's going on here? Well, one of the things that I think is a differentiator is how healthcare oftentimes thinks of things as vertical integration. They want to drill down in terms of, I want to focus on a specific disease. Whereas horizontal says, I want to focus on the person. And they're organized around persons or communities. And that's not really so convenient for healthcare organizations to pay and reimburse people for persons, whole persons and communities. It's easier to say, how did you meet X number of targets to address this individual? But this is something I think it's a tension that we have to hold on to in primary care, that our value and where we really gain our merit is whole person care and addressing what's most useful to that patient today. And so this brings me to what I consider kind of this boundary spanning role. Again, these are the unique aspects about primary care, is that we personalize care. We put it in context of those patients. A physician might have 3 hypertensive patients with different ethnic and social backgrounds, and they might personalize the approach to 3 blood pressure management approaches, still consistent with evidence-based guidelines, mind you, but they're personalized to that individual. Integration of care is something that all of us work on a lot and in IPC teams, but it's part of the puzzle that really helps, I think, boundary span so that it's not all put on one person, but it's our team of integrated providers that provides the more whole person care. Primary care also offers a safety for individuals where they might feel otherwise not safe to report problems or address issues, that here we provide a place that's safe and maybe they can disclose where they need help that they wouldn't otherwise know. And finally, knowing that individual and family has been the hallmark of primary care. You know, in the old days, it used to be that you knew everybody in the community. You know, you were the primary care physician in a small town and you knew everyone there. Well, primary care has certainly expanded, and so, but what we hope we have is we know our panel of patients well. We know when we see the father, we maybe know the mother and the child too. And so we know certain things that are going on in that family. But I would offer is the next stage is better knowing the community, the context in which those people live their lives. And this is, again, where we step outside of our boundaries and look at those. So what I offer to you is some of the next steps for you are what's happening in your institution for population health care, what's research going on in your area, and what are organizations you might be able to begin to collaborate. Think more broadly. You know, what's happening in the community. This Everyone project, if you go to that site, it's a neighborhood navigator and you can put in your zip code and you can find different resources to help address needs of your patients. So in summary, what I hope I've talked to you today is the basic tenets of population healthcare, how it applies to integrated primary care, and the conceptual shifts that each of us need to go to move to more of a population-oriented approach. I list here just a couple resources. One is an idea of community partnership ideas, and then the other is a CMS guideline that talks about some of the things I talked in my talk about those, and they drill down in more detail of sort of a package that you could get to talk about empanelment more or some of the other aspects there. So hopefully I left enough time for some questions and some answers. So I'll stop my slideshow there.
Thank you, Dr. Vogel. That was a wonderful presentation. I know when I was listening to you, I was thinking about how, you know, when you're bringing on a new psychologist or social worker or a licensed professional counselor, really having to dive down into this idea of population health, especially if they've really been in private practice, focused on the individual at 25%, that you noted at the top of your pyramid. And so I'm wondering, even in your own experience, how you might explain how population health would look like in someone's day-to-day clinic or in their clinic conversations.
Yeah, I think one of the things that's so important in people working in primary care is telling the story. And I think what's useful to me is understanding how primary care was originally developed. family medicine was sort of the radicals of the 70s, if you really think about it. They came up and said, you know, this internal medicine, general internal medicine, just from the head up to the neck, that's not whole person. And so I think if we can begin to kind of conceptualize, we're interested in the whole person who comes into our clinic. And again, some of the ideas we talk about is, you know, that there's no wrong door. You know, you've come in here, we're here to help. We can help find where you need to go if we're not it. But you know, being able to kind of not turn people away, if you will. And so that idea of we are really we're kind of a counterculture from traditional medicine. This is really more inclusive, if you will.
Thank you. Thank you. It looks like we also have another question from Ronald O'Donnell. He says, thank you, Mark. What are workforce challenges and solutions to implementing primary care population health?
Well, Ron is well aware. He's trying to help solve this gap for us. Arizona State University, I believe, has their BHC program. You know, and what's really true is that it is hard to shift someone from who's been in specialty mental health care to kind of begin thinking about what is primary care. And so certainly Barbara Ward Zimmerman, you and I and the whole team created some curriculum to help kind of deliver that. I think that we also know about our certificate programs, University of Massachusetts being probably the most popular, but there's also University of Michigan. I know there's other ones that are helping to kind of expand that. But I think that one element of that is, you know, as people are trained of understanding the importance of population health in that onboarding process. And Ron, correct me if it's not, it's ASU, right? Other questions? I know there's got to be some questions out there.
We have someone who unmuted, so I'm assuming they
Oh
might
no,
wanna-
did I get caught? That's the well, I didn't have a question. I was more just gonna play off of what Brittany had said of talking about like how people recognizing that rising risk. And we actually, in one of our faculty meetings yesterday, were talking about like the difficulties of managing productivity and warm handoffs and trying to mitigate burnout. And one of our staff members was like, well, you know, it's harder for me who came from specialty mental health of when I get someone who is in like, oh, they kind of want to talk to someone. And, you know, if it's urgent, like I'm there right away. That's something, you know, if I'm overbooked or whatever, trying to find that. And he was talking about his difficulty when it's more of that big population that we saw at the end. And I was so happy that he felt comfortable to bring that up because it's that highlight of shifting that perspective of what, you know, creating that moment and what value you can bring to be that first touch to someone that wouldn't have sought out behavioral health in any way, or kind of creating that opening to be able to do more prevention work. And so I think it's just finding those opportunities among staff continuously to help shift that perspective when they're not from that world, or maybe creating a sense of urgency around all warm handoffs rather than just the ones that are like really critical or urgent.
Yeah, and I think that part of that process is that when we go in to see that patient, it might be just normalizing their experience, and that's all they need. They just need someone to say, yeah, it sounds like you're on the right track. You know, this isn't, you're moving along, and that helps someone immensely. You know, one of the questions that I thought I would get more of is how do we pay for this? Because I think that that is one of the challenges. And many, again, as I alluded to, that so much of our system is made up of looking at metrics, you know, how are we affecting diseases, and has less focus on how we treat whole patients. And I think that one of the things that I thought was originally a great promise was the ACOs, the accountable care organizations. You know, they sort of, to me, seemed like they were the better version than managed care, that they were really a sense of covered lives and how can we address them with sort of in a capitated program. Unfortunately, those really became run by health insurance companies. And I think one of the future is ACOs that are run by medical providers, that it shifts, that their priority is shifting from less of a financial direct measurement to allowing primary care to do what it does well. And I think there's hopefully we'll see some better examples of that coming out in the future. But I think that value-based care continues to come. It's, you know, everybody said it was going to be here by now, but we're still on a fee-for-service world by and large. But I think all of us need to be thinking about how we're shifting to value-based care over time. I can give a funny example of that as a colleague of mine that Ron knows too. He was Jeff Leichter. He worked and developed integrated primary care in all these clinics, and his manager came or boss came to him and said, "Got good news for you, Jeff. Your system cost this 2,000 $2 million less this past year. The problem is we're not capitated, so we lost $2 million because of that." So, you know, until what we do gets rewarded by the cost savings that we're addressing, fee, uh, fee for service care is never going to kind of get at whole person care. So it's one of the real challenges. I don't have answers to that one today.
It also kind of makes me think of Tara, I know you brought up this idea of like productivity and warm handoffs and those high necessary urgent probably SI or in that top 25% of the population. And I also wonder how we are incentivizing our BHCs, right? If we're saying, okay, only handoffs that are billable with the diagnosis count towards your productivity, right? Then they might be disincentivized to go to one of those healthy people and do the validation because it might not have a diagnosis attached to it.
Yes, I would offer that that is one of the real downsides that I think we need to keep advocating for, is how the work that we do gets valued by how it affects the lives of the patients we touch versus the direct billable hours. And unfortunately, there's still an emphasis on that. You know, Stacy points out a really great thing about CPT codes. There are more codes now for prevention, and than there were before. And I think with usually not billing as successfully or as much as some of our diagnosis codes are, but I think it's getting there. So I'll read this one from Robert. In a large medical system as a health psychologist in the community, trying to introduce my services. I'm directed to psychiatry, who focus on the 25%. We talked about the top of the pyramid, and they're really talking about specialty mental health care, right? Rather than community health and improving holistic treatment. In your experience, there's another role in the hospital that tends to be more open and thinking about broader health promotion and disease maintenance. And the answer is, I think you need to find physician partners that are primary care. And it depends sort of on your healthcare organization, how it's organized. I was at a smaller community hospital where our chief of the medical staff was a family physician. And so we could get greater leverage by working with that group. And we've never had success in our psychiatry focused outpatient care. They really kind of delivered one element. Rehab psychology is the other one. We just were we on a talk the other day where the guy was really talking about how rehab is, they have as part of their condition kind of seeing patients routinely. So they have standing orders for rehab patients, whereas sometimes in the hospital, if we want to address in hospital consultation liaison service, we have to get referred, whereas rehab, sometimes those can be seen more directly. So I would offer, you want to kind of pair with primary care physicians to see how you can leverage your services to what, because they're the ones that really are going to see the need and help address that. So.
Thank you very much, Dr. Vogel. I just saw the time, and I do want to be mindful of everybody's time and get a couple words in that I need to get in before we leave. Thank you once again for attending the webinar today. Remember, if you would like to see credit for attending this event, please respond promptly to the evaluation link, which will be sent via email shortly. We will leave the evaluation open until Thursday, May 2nd. CE certificates will be sent via email within 5 to 10 days after the evaluation period closes. And remember, you are encouraged to submit an evaluation even if not seeking credit. Feel free to email us at admin@societyforhealthpsychology.org if you have any questions. Again, thank you to our speaker, Dr. Vogel, for an amazing presentation. And I think this is one of the things that we were hoping to really, like, this is what we want to drive. How do you create that shift in identity as well, where we're not the ones focusing on the 25%, but really everything below that pyramid, that base of the pyramid. So I think your talk just really highlights the importance of thinking about ourselves as in a different way than what we were trained to think of ourselves as. Thank you so much, Dr. Vogel, and everybody for joining us today.
Thank you for having me.